So I'm going to go through the broad gamut of issues that relate to atrial fibrillation from a procedural perspective. We'll talk a little bit about managing rate control in patients for whom the goal of sinus rhythm is no longer an option. We'll talk a little bit about procedural options for trying to restore and maintain sinus rhythm. And then at the end, I'd like to talk to you a little bit about a research area where we're interested in bringing in some of what you've already heard about new anticoagulants with some procedural options or monitoring options to reduce the risk of stroke in patients with atrial fibrillation. So the goals of atrial fibrillation management for all of us are first and foremost to prevent thromboembolic complications, and as you've heard, that most notably means strokes. To control the symptoms associated with atrial fibrillation, and then in the occasional patient who has weakening of the heart muscle or left ventricular dysfunction as a consequence of atrial fibrillation, to prevent or to prevent that dysfunction from beginning and reverse it if it's occurred. So the symptoms related to atrial fibrillation generally encompass palpitations, shortness of breath, chest pain, and fatigue. And we manage those by, in most cases, slowing the heart rate. And we either do that by, as I'll show you, medications or procedures. Ventricular rate, very rapid rates, can be treated with beta blockers, calcium channel blockers, digoxin, AV junctional ablation, which we'll mention. And then finally, for those patients who don't like the sensation of loss of coordination of the top of the heart and the bottom of the heart, antiarrhythmic drugs or catheter surgical ablation. So how do we achieve rate control, and what are the consequences? Well, the acute and chronic consequences of inadequate rate control, as noted, are fatigue and dyspnea and palpitations and tachycardia-induced cardiomyopathy or weakening of the heart muscle. The procedural option, once medications have failed, is directed towards reducing the number of impulses or the heart rate that's generated by the top of the heart getting to the bottom of the heart. So this is a schemata of what we think atrial fibrillation looks like. It's many, many different little circuits in the top of the heart, shown here in these blue half circles, all making their way through the AV node, shown here with the larger arrow, which functions as a toll booth in most patients. So we have our own built-in mechanism for slowing the heart rate, but in many people it's inadequate, and rates can be 160, 200 beats a minute. An AV junctional ablation involves a very simple procedure where a catheter is placed through the leg with local anesthesia, and that area, that AV junction, is destroyed. It's a 4 or 8 millimeter catheter, so very small. Heat is generated at the tip of that catheter, and the tissue can be destroyed quite easily. So there's no more impulses traveling from the top to the bottom of the heart. The critical issue with this is that when this gets done, the heart no longer has the ability to generate its own reliable pacemaker from below that region, and a permanent pacemaker has to be implanted. This is what it looks like. Catheters here shown on the left side. It's just a fluoroscopy or X-ray image. In this case, there's multiple catheters, but the catheter called a Rove catheter is the ablation catheter. And if you look at the left side of this tracing, there are lots of complexes occurring very rapidly with a very rapid heart rate. We turn on the RF, the energy, and all of a sudden the heart rate slows quite dramatically and gets taken over by permanent pacemaking. So this is a highly effective procedure. Most patients who have this procedure feel dramatically better. In fact, I would say from a symptom control standpoint, there are few things we do that result in better symptom control. In general, it can eliminate the use of drugs, so beta blockers, calcium channel blockers, and digoxin, and generally some combination of these medications is required for patients to achieve rate control, and by doing this procedure, we can essentially eliminate the use of all of those medications. If rapid rates had caused heart muscle dysfunction or a tachycardia-induced cardiomyopathy, this procedure often can normalize that heart function and make it return back to a normal function. The negative aspects of this procedure, and part of the reason why we do it quite a bit less frequently than we used to, is because we've now learned that there are small numbers of patients who actually can develop worsening of their heart function when they're relegated to obligatory pacing. So you do this procedure and the patient's 100% dependent on their pacemaker. Once they become 100% dependent on their pacemaker, there are certain groups of individuals who will develop worsening heart function. As noted, patients are pacemaker dependent once this procedure is done. Pacemakers are highly reliable. We've had no major changes or recalls or dysfunctions of these devices in the last 20 years. That's in contradistinction to defibrillators, which you've all heard about recalls for. Pacemakers have been remarkably reliable. But once you are dependent on a pacemaker, if there is an issue with it, if you develop an infection and the pacemaker becomes infected, then you have no underlying rhythm, and that requires quite a bit of management in order to get patients through that phase of difficulty. And then finally, there is a risk of polymorphic ventricular tachycardia, which is a potentially life-threatening rhythm. And in the early days of doing this procedure in the mid-1990s, there were patients who died post-procedure because of this very rapid and dangerous type of ventricular tachycardia. We've now learned that pacing the heart at about 80 beats a minute for about 6 weeks after this procedure can entirely mitigate that risk, and this no longer is a complication as long as we're fastidious about pacing the heart at a reasonable rate for at least 6 to 8 weeks. I'm going to switch gears now and talk about mechanisms to keep the rhythm normal, and those are what we term non-pharmacologic strategies for maintenance of sinus rhythm, and these can be catheter-based, involving catheters placed again through the leg into the heart, or surgically done through minimally invasive or through fully invasive surgical approaches. In both cases, the principle is the same, and that's to eliminate the interaction of targets or extra beats from the body of the left atrium and then the development of atrial fibrillation. So our current sort of state of very complete understanding of atrial fibrillation is shown here. This is the back of the left atrium. These are 4 pulmonary veins that plug into the back of the left atrium, and we believe that in certain individuals, and that's probably on the order of 6 to 10 million people in the United States, sleeves of pulmonary tissue, of muscular tissue, exist within these veins. They can begin to fire on their own, to develop their own spontaneous electrical activity, and then make their way into the body of the atrium. And in the vulnerable individual, that can initiate atrial fibrillation. So the principle for pulmonary vein isolation is to electrically isolate the pulmonary veins from the body of the left atrium, and we can do that through any type of lesion at the orifice or at that junction point between where the vein ends and plugs into the body of the left atrium. This is shown here from a catheter perspective. Catheters are placed through the leg into the right side of the heart. We then puncture the septum or the membrane between the right and left atria, get over to the left side, and then make a series of ablations to electrically isolate or create a barrier between the pulmonary veins and the body of the left atrium. So this is looking at the left atrium, looking through one of the pulmonary veins from the inside, and essentially a catheter is placed along that orifice and lesions are created. It's done like this, but in fact, it's quite a bit more difficult than simply doing that. This procedure takes a few hours. Optimal candidates at this point are patients who have failed at least one drug therapy, and in fact, in the United States, you have to have failed at least one drug therapy to get most carriers to approve this procedure. Paroxysmal atrial fibrillation certainly is the group of patients that we target in this procedure as the highest likelihood of success, and we define success as a 70% reduction in symptoms or cure, and that cure is probably about 20 or 30%. So the really realistic way to present this procedure to patients is to say that about 70% of people feel better after they've had this procedure. They have fewer symptoms. Many of those patients have substantially fewer recurrent episodes of atrial fibrillation. It is possible that we're curing some people, but honestly, we've not been doing this procedure long enough to know whether we're really curing it. We've been doing it since about 1999, 2000. I've seen patients now that we did in 2000, 2001, having their first recurrences now in 2013. So we thought they were cured, but we're seeing recurrences later on. The major risks, and there's about a 10 to 15 to up to 20% likelihood that we'll recommend a second procedure for a recurrence that occurs after a month post-initial procedure. So the risks of the procedure are about a 1% risk of procedurally related stroke. There is a small risk of something called an esophageal atrial fistula, and that's a connection that gets generated between the back of the left atrium and the esophagus, which lie in very close apposition to one another. And then about a 1% risk perforating the wall of the heart and having blood accumulate around the outside of the heart and causing something called pericardial tamponade. So about a 2% risk in general, 1 to 3% risk of significant complication. So what are the facts and what is the fiction associated with pulmonary vein isolation? Most patients, in fact, will feel better after this procedure. Most have a reduction in what we call the burden of atrial fibrillation, and I'll talk to you a little bit more about that concept. But essentially, it means the frequency and duration of recurrent atrial fibrillation episodes. Honestly, we don't know the long-term efficacy of this procedure. There's an awful lot written on the internet. I don't go a day without having patients bring me in reels of information from the internet, and a lot of it is advertisements from people, from labs. But in fact, the truth is we don't really know. And honestly, until we understand atrial fibrillation better than we currently do now, we probably will not reliably cure this arrhythmia. But we do, I think, achieve a significant reduction in symptoms. 30% of patients will remain on an antiarrhythmic drug. So when you look at that 70% efficacy rate, 30% of those patients are still on an antiarrhythmic drug. They were probably less well managed on that drug prior to the procedure, but they remain on it afterwards. And then about a 2 to 3% risk of serious complications, somewhere between a 15, 20%, maybe up to 30% chance of needing a second procedure. That has a lot to do with how aggressive the electrophysiologist is in recommending a redo. So what's the fiction? And this is very important. PVI is a curative procedure. Most importantly, PVI can be performed as a way to get off anticoagulation. I spend a lot of time dispelling this expectation from patients. We don't do this procedure to stop anticoagulation. We do this procedure to reduce symptoms and improve quality of life. The procedure has become more effective. In fact, I don't think it's a lot more effective than it was 10 years ago. I think it's slightly safer because the imaging and mapping technologies that we use to perform this procedure are substantially better than they were, but the efficacy is not dramatically different. So again, this is the reason that many patients come and ask to discuss having this procedure. If I have an ablation, can I stop after anticoagulation? And if so, when? And the answer is a resounding no. Unless you didn't require anticoagulation before the procedure, you need to stay on it afterwards, unless we do something, as I'll mention in a protocol later, to potentially feel very good about the fact that we're seeing no asymptomatic atrial fibrillation. So what's new in approaches to thromboembolic protection in atrial fibrillation? And the rest of this talk is going to be largely investigational or research-based. Left atrial appendage exclusion and consideration of anticoagulation based on the frequency and duration of recurrent atrial fibrillation episodes, or AF burden. So as already shown to you from Dr. Goldhaber, clots, we believe, in atrial fibrillation most of the time originate in the body of the left atrial appendage. So this is shown here at the top, the left atrium, and then there's a little structure off to the side called the appendage, and that's a clot lying within the left atrial appendage. We know that in the large majority of patients who have strokes associated with AF, that's because of a clot that initially was present in the left atrial appendage and then, as shown here in time sequence, migrates so that here there's no clot any longer present in that body of the left atrium. So one could, I think, logically surmise that if you could get rid of that appendage, you could dramatically reduce the risk of stroke, at least in some patients with atrial fibrillation. And this is a procedure that's been done. This is a surgical approach to exclusion or resection of the left atrial appendage. I should tell you from the outset, we have no convincing data at this point that getting rid of the left atrial appendage actually reduces the stroke risk in atrial fibrillation. This used to be a routine part of cardiac surgery in the early days of cardiac surgery when most surgery was being done for patients with mitral stenosis. It was found pretty quickly that it did not reduce the risk of stroke, in large part because people with rheumatic heart disease get clots frequently with atrial fibrillation, both within the appendage but also in the body of the left atrium that's in no way being targeted by this procedure. But in patients with non-valvular atrial fibrillation who otherwise have pretty normal structural, are fairly normal structurally in regard to the left atrium, this does make sense as an option, and it's a fairly simple procedure to perform. Hopefully we'll see it here. This is a surgical approach done minimally invasively. This is a stapling device, and you can see it being rotated around. That structure appearing in view now is the left atrial appendage. It looks like a rooster's frond. It's pulled up, and then the base of the appendage can be clipped off quite easily. So that's resection of the atrium. It turns out that suturing this closed is not terribly successful. The sutures come undone. In a large percentage of patients, when we look at them a year or two later, the appendage is now open again. So you really have to take it off and staple it closed to feel confident that you've completely eliminated the structure. And this is what it looks like when it's excised. There's a great deal of variability in what the appendage looks like from patient to patient, but the surgical approach really deals with all of those types because you pull it up and you cut it out. As I show you in a second, the catheter-based approach to this is a little trickier because of that. There are now a lot of devices that have been developed. There's 3 devices that have been developed. In this most recent type of or iteration of device, you're not putting a device within the appendage to close it off, but in fact you're closing it off with a lasso. So these are all techniques which are now in various stages of development and approval. Once again, I have to tell you that they're being used. You can get them used, but the data at this point is not fully validated, in my opinion, and I would strongly recommend that anticoagulants still be used as the primary therapy, and this be reserved for patients who are not candidates for anticoagulants. In the last couple of minutes, I'd like to talk about this concept of AF burden and get back a little bit to what Dr. Goldhaber mentioned and to what Christian mentioned using 2 concepts that you've heard already. You heard a lot about the CHADS score and the CHADS-VAS score, and one of the very striking components of those risk categories is that nowhere in that risk scheme is the pattern of atrial fibrillation mentioned. So the CHADS score and the CHADS-VAS score use clinical associated factors. So the presence of age in the CHADS-VAS score, it's anyone over 65. In the CHADS scoring system, it's anyone over 75. Hypertension, diabetes, a prior stroke or TIA, the presence of congestive heart failure and other types of risk factors. But there's no discussion about whether the patient's in atrial fibrillation or not in atrial fibrillation. It doesn't make it into that risk scoring system in either of those 2 categories. And currently the standard of care is to completely disregard the pattern of atrial fibrillation. And the reason for that is that there's been data from those early trials that generated the CHADS and the CHADS-VAS scoring system to show that, in fact, there's no stroke risk difference between patients who are in paroxysmal atrial fibrillation and patients who are in chronic AF 24 hours a day, 7 days a week. That's probably the most intuitively difficult thing for people to understand and to accept for very good reason, because it essentially takes AF out of the picture. It says this is the ticket that gets you into consideration, but the characteristics of the AF itself don't matter. We're beginning to, I think, see data that may challenge that concept, and that's where this idea of burden comes in. If we were to ever consider a protocol where we were choosing to anticoagulate people based on their atrial fibrillation burden with the idea that maybe if you don't have any atrial fibrillation at all, if you're not having any recurrent atrial fibrillation, we could in fact discontinue your anticoagulation. The premise would be that we can continuously monitor patients all the time. And in the trials that got patients that generated the CHADS score, even those patients with paroxysmal atrial fibrillation most likely had an awful lot of atrial fibrillation for them to ever make it into these trials. We now, with devices, and I'll talk to you a little bit about these in a second, dual chamber pacemakers, ICDs, and subcutaneously implanted monitors that don't have any leads in the heart, now give us the opportunity to identify atrial fibrillation that's occurring for minutes at a time, for very short duration, and in fact monitor people remotely in a continuous fashion. I mentioned that there's now some data to show, in fact, that there may be short durations of atrial fibrillation that in some patients are not highly associated with stroke risk. And I won't bore you with these studies, but just to say that there's increasing data to suggest that there, in fact, is a certain amount of AF you have to have in order to generate a stroke risk. And the most recent of those trials is the ASSERT study in a pacemaker population. You only needed 6 minutes of atrial fibrillation in this study, a minimum of 6 minutes of atrial fibrillation to develop a signal or a stroke risk. But in fact, the greatest risk of stroke, and it was quite a bit higher than at shorter durations, was not present until there was at least 17 hours of stroke a day. So a relatively significant burden of atrial fibrillation. The truth, in my opinion, is probably going to be somewhere between 5 hours and 24 hours, but it's not going to be a few minutes of atrial fibrillation a day in certain groups of patients. A very interesting study is shown here, and again, I'm not going to go through the details, but it's a trial of about 560 patients who had pacemakers in place, and these investigators looked at stroke rates, and they stratified them in these patients based on their CHAD score and their burden of atrial fibrillation. And what they found, which I suspect is going to be likely the truth, which is that patients had the highest risk of stroke if they had a very high CHAD score, pretty much regardless of how much atrial fibrillation they were having. So low burden of atrial fibrillation but a high CHAD score placed you at significant risk. However, high burden of atrial fibrillation was present and was necessary in those patients with a low CHAD score to generate a significant stroke risk. So sort of a dichotomy. High CHAD score patients, multiple stroke risk factors. The presence of atrial fibrillation probably is not that critical. Those patients all need to be anticoagulated once we've seen NAF. But the question becomes, now that we're using the CHADS VAS score, and if we're going to use the CHADS VAS score the way the Europeans are using it, anybody with a CHADS VAS score of 1 or greater gets anticoagulated, which basically means if you're not a woman, if you're a male under the age of 65, and you have a chance of not being anticoagulated. Everybody else basically gets anticoagulated. Over 95% of the AF population gets anticoagulated with a CHADS VAS scoring system. That's a very critical thing. Only 5% of patients with atrial fibrillation will not get anticoagulated if we adopt the CHADS VAS scoring system. And that may be the right answer, but I would hope that in those low CHAD score patients, if we can document the low burden of atrial fibrillation, we may be able to reduce the use of anticoagulants in that group. And these are the options. On the top is the Reveal. It's a small device that gets placed underneath the skin. Pacemakers and defibrillators look like as shown below, with a device with 2 leads in the heart. This is the schema of how one can use these devices to wirelessly download. These devices all wirelessly download to a monitoring station which is present in a patient's house. You can download it via a wireless phone or through a landline, and that data goes to a central monitoring station, gets processed, and we can make decisions as clinicians. I, on my iPhone, have a link to the monitoring station for these different companies, and when a patient of mine sends in a transmission, I get notified and I can look at it and make a clinical decision based on it. So using these concepts, we have 2 trials that are now ongoing. One is called Tactic AF, and one is called React.com. And again, I won't burden you with the details of these, but essentially, one's a pacemaker study, pacemaker ICD study, and one is a study, React, using that subcutaneous device for patients who don't have a pacemaker or ICD already implanted. And there are 2 protocols that are quite similar in patients with a low stroke risk, a CHAD score of 2 or less, who then are able to discontinue their anticoagulation if they're not having atrial fibrillation and reinitiate it when they have recurrences. We've been waiting to do these trials for a number of years. It was irrational to do them with warfarin because of what you've heard about the pharmacokinetics of that drug and the inability to get it started and stopped in a timely fashion. We now have 3, and hopefully in the not too distant, a 4th rapidly acting anticoagulant, which is perfectly suited to this pill in the pocket or tailored form of anticoagulation. These are the prototypes. These are pilot studies. We hope eventually to have definitive trials, and someday, in fact, to allow patients to make these decisions themselves based on monitoring that can be done through their smartphone. There's no reason that patients with appropriate risk characteristics can't manage their anticoagulation the way diabetics manage their blood sugar with relatively minimally invasive means, but these trials are the ones that we need to do hopefully to get to that point. So with that, I'll say thank you and go to the post-test questions.